Hello, everybody. It's your favorite physical therapist, Jared, coming at you with resilient rehab and wellness. And today we are going to be continuing our shoulder series. Okay. The first episode of the shoulder series was just reviewing some of that basic anatomy, just the bones and the muscles, right? The joints and the muscles there. Before we get into today's episode in the shoulder series, please go on ahead, give this video a like, share it, subscribe, help a brother out. I appreciate it. And I tell you what, man, like the intro shows, it's getting cold out here for a lot of us. And I really wish I had some warm weather and the beach right now, man. All right, guys, let's get after it with part 2 of the shoulder series. So today's episode, we're just going to go over some of the most common shoulder related injuries that I tend to see and that are just common in an orthopedic clinical setting. And we're going to start off with good old rotator cuff pain, something that I think a lot of people hear. Not a lot of people know exactly what's going on when it comes to the rotator cuff. So as we mentioned in the previous episode, your rotator cuff consists of 4 main muscles. Okay. 3 of them live along the back of your shoulder blade. 1 lives kind of deep in the front of your shoulder blade. All 4 come around and attach to the front of the shoulder joint. Okay. And their job is to help stabilize the joint by stabilizing the head of the humerus. Now, there are varying levels to really all the injuries we're going to go over today, and that includes the rotator cuff. And so I tried to find an image, and like usual, guys, I don't own the rights to any of these images you're going to see. Shout out to the people that do. It is not me. So not taking any credit there. Like this image shows, I like this image a lot because it's showing you a progression. So it first brings up our tendinitis, which just like it is in the name, anybody know that itis, right? We tend to say that when we've eaten too much, we got that itis, that food coma. Well, tendinitis is inflammation as well, just inflammation of that tendon. Now, some people will call it an itis if it's considered acute, right? But the definition of acute is changing. Acute does not always mean that it's going to be something that's happened very, very recently, although that is common to line up with that, to have a direct correlation there. But acute can also just mean how inflamed is the tissue. So just think of it that way. It's just inflamed tissue, and you're going to have pain, right? We're going to have pain in that area. It might vary, it might not be all the time. The more common motions that are going to reproduce that pain, and part of it can depend on which specific tendon is irritated, but more common, you're going to see pain with different rotating positions, whether it's rotating back, trying to reach behind your back, and then reaching across the body and having some rotation there as well can cause some of that discomfort there. And some overhead positions as well. Okay. That can then progress to, if not addressed in an appropriate amount of time, that can then progress to what we see here called tendinopathy. All right. So you have tendinitis, you have a tendinopathy or tendinosis. What can happen with that is a more severe version of that initial just inflammation. Now, when we progress to more of a tendinosis or a tendinopathy, it's been something that's been going on for a long time. That irritation to the tendon's been there for a while. Not always adds that same acute kind of sharp, uncomfortable feeling. It can morph into a little bit more of just a dull, chronic ache. But the limitations can continue to increase and be similar to that of the tendinitis, but more pronounced. So more limitations in those rotating positions, more limitation with reaching across the body and adding some of that rotation in, more limitation with being able to reach overhead. And then that can also progress to a full-blown tear, right? So where we have a separation of the tendon. Now, this is not like what most people think, right? And I explain this all the time. I'm going to grab a sheet of paper here. Imagine our tissue folded up because there's layers, right? So there's layers to the tissue. So I'm folding this piece of paper, okay? So there's layers here. Now, it does not mean, a tear does not mean that you have completely separated the tissue. That is not what it means. What a tear would mean is if we have layers, right? If this is my tendon, I can tear through each layer. Now, it doesn't have to be, again, that there's this full separation, but I can tear through multiple layers of that tendon, and you can still have what's called a full thickness tear. Now, there you can also have a partial thickness where you have just part of those layers are torn. Okay. Now, you can still have that full-blown complete separation too. And that's a much more intense version. I like to always go over that because it's very, I think it's not as intuitive. You hear tear, you think, okay, there's two ends and they have come apart. So, and that's not always the case. Usually it's going to be uncomfortable. Okay. High levels of pain here. Unable to raise that arm overhead is the biggest thing you see. Yes, all those other limitations are certainly going to be there. The biggest one I tend to see with this, because again, now you no longer have stability of that humeral head, top of the humerus, top of that upper arm bone for that ball and socket joint. You no longer have stability for the ball. And so now when we try to raise our arm overhead, instead of this fluid motion, what you're going to typically see is this. That shoulder just gets drawn up because there's nothing on that seesaw effect to help it get sliding down. And so that arm comes up and it gets stuck and it's painful and it's uncomfortable. And that is our rotator cuff sequencing there. Okay. Let me know if you guys have questions throughout. Obviously, this is not a live video, so I can't respond to your questions in the moment, but I would love comments, questions in the chat. Always here to answer more questions, guys. This is what this is all about. It's supposed to be some back and forth here. And for my other healthcare providers out there, if you guys think I missed a pivotal point in explaining some of these injuries, if you think that there's been even more updated research that might debunk any of the things I say, let me know. Always down to have those conversations and to nerd out with you. All right, next up here, guys, we have subacromial bursitis and what's called shoulder impingement, or more commonly known in the clinical world of subacromial impingement syndrome. Okay. Syndrome meaning there's a bunch of different things that could be going on, so they don't always know exactly which one it is. That's kind of where syndrome gets its term. But let's start with the bursitis, which is kind of falls under the umbrella of your more generalized shoulder impingement. So now we specifically chose this bursa because it is the more common one to get irritated. Now, I know there's my healthcare professionals out there that don't necessarily believe in the ability for bursa to be a reproduction of pain. There's some, at least I've heard this from various mentors, that there is some competing research out there about how vascularized the bursa is. And if it's not well vascularized and doesn't have a lot of neural components to it, how is it signaling to the brain that it's painful? But that's a conversation for another day. So what is a bursa, right? It's a weird term. Bursa is a fluid-filled sac. It is strategically located in and around our joints in order to provide additional cushion. You're starting to see a theme here, right? In episode 1, we talked about different cartilage that provides cushion, right? Again, these bony features that we all have are not these nice smooth surfaces. Things are not fitting perfectly. So the body has all of these additional barriers in place to really help protect us from ourselves, and bursa are one of them. Now, when we're having the subacromial bursitis, again, we see that itis, inflammation of the bursa, simple as that, right? So that tissue there, that fluid-filled sac, has now gotten irritated, as we see in this left image here. And I like this picture because you see one where it's quote unquote healthy and one where it's getting red hot because it's irritated and swollen. Okay, so you have that bursa. It's now irritated. When anything gets irritated, you certainly can have a little bit of swelling. Fluid starts to build up even more there as a response to the irritation, right? How do we know if we have this? Great question. A lot of times with subacromial bursitis, I find that it is best diagnosed through process of elimination, meaning we do all these other tests that we would do for the rotator cuff or what we're going to look at with subacromial impingement syndrome. And none of those things are quite coming back positive, but the location of the irritation is there. Another one that's just easy is that when you distract the joint. So if I provide some tension and I take that humeral head that you see, so we have the humerus here, you go up. When it gets a little bit more circular here, that's when it becomes the humeral head. And you pull on that upper arm bone gently and just open that space up. Imagine it just letting everything breathe there. And that usually feels a lot better. A lot better. So that's an easy one to say, hey, okay, even if this isn't the primary source of your discomfort, we know that this is something that is going on in there and we can help relieve that. And we're going to treat it really how we treat the shoulder overall. And that's coming in the next episode. Now, we have shoulder impingement syndrome, subacromial impingement syndrome, shoulder impingement syndrome. You see these terms really intertwined a lot, probably more than they should be. Again, a syndrome means that it could be a slew of reasons for why it's happening, but the gist of it is that underneath what's called our acromion, which we will be getting into in a little bit, and we reviewed that in the first episode as well. Underneath the acromion, you have tissue there, and something underneath the acromion is getting impinged. It's getting pinched, irritated, and therefore inflamed. Okay. It could be the muscle tendon. It could be the bursa. It could just be the joints themselves that are getting irritated. Why? Again, it's a syndrome. It could be a slew of reasons. I find that more times than not, the underlying cause is that the timing is thrown off somewhere in the complex of the shoulder joint. We have a lot of these competing forces inside the shoulder joint that are looking to push and pull and rotate and distract down and twist and these things. And if the timing is off, whether it's due to one muscle being tighter than it should, the capsule being a little bit more restricted than it should, maybe some muscles are a little bit weaker than they should be, I find that any of those reasons are common reasons to do what ends up being the more umbrella term of the timing is thrown off. So a motor coordination restriction there. Now, one of the best ways to rule this in is what you see on the image here, painful arc. So when you're trying to raise your arm out to the side, raise that arm out to the side, raise the roof, you see that there's a certain range here where it becomes painful. And again, that's where that timing gets thrown off. And it's in this range usually where other muscles cannot healthily compensate for that timing being thrown off. And so right in that 60 to 120 degrees is where you're going to get that pinching occurring underneath the shoulder. That's one of the easiest ways to rule it in. Again, what's the primary cause? That can be a number of things, but to help rule it in, that certainly is an option. And then you can see, okay, don't get it twisted. As you see, this supraspinatus muscle and its tendon underneath there, well, supraspinatus is a rotator cuff muscle. So you certainly can still get some of those rotator cuff other tests to be positive, right? If anything you do to further close down this space, anything you do to put some tension on the tendon, if the tendon's irritated, is going to reproduce more symptoms. Another super common one, right? So we have that mid-range, that 60 to 120. You also take it all the way overhead and you provide overpressure at the end range of that motion. Anytime you go end range at a joint, you're most likely going to be further extenuating the joint surface contact there and can get some irritation there too. All righty. I'm trying to keep this short and sweet for you guys and keeping it really to just break these things down so you can be a little bit more aware of what your shoulder might be telling you. And with that said, we are moving on to the labrum. Now, with the labrum, okay, yes, you have a labrum in your hip, but you do also have a labrum in your shoulder. And we briefly chatted about this at the last episode, what that labrum does, right? It increases the joint surface area. to allow for more motion and safe motion, stable motion inside the joint. It also provides, like our bursa, right? That cartilage it also provides with its own cartilage to give you some cushion. So it's not just bone to bone trying to maneuver the shoulder itself. And then in addition to just widening more space and providing that cushion, it's a lubricant. So it just makes everything just nice and smoother. Okay. Now you're going to see the most common tear that's pointed out here. This is typically your location of what's called a slap tear. So superior labrum, meaning the top of it, anterior, the front, posterior, the back. So you can have that kind of slap tear here. And this is a really good picture because this is how these injuries a lot of times start. Rotator cuff starts this way too. It's more of like this fraying that you see here of the labrum. Very rarely, unless it's a really unique traumatic event, very rarely are you going to see where you go from tissue to all of a sudden separation. It's also going to be very rare that you go from tissue to all of a sudden a tear there. A lot of times you get those frayings at the end, and then that just builds and builds over time. So yeah, that's one of the most common ones that we see. There are a few others. If you go a little bit lower down to the more inferior portion or bottom of your labrum, you're going to get a little bit more. You're going to get a little bit more of what's called a Bankart lesion. There's a Hill-Sachs lesion. All in all, various types of injuries to the labrum of the shoulder. And what does this feel like? Be deeper pain usually, which can be really hard to assess. If you're the patient, like I get it. It's really hard to be like deep, understanding, okay, deep pain versus pain I can touch. But that is one of the best examples I try to give. I say, hey, does it feel like it's deep in the joint? Like you can't really touch it, but there's something wrong there. Or does it feel like you can press around and be like, oh, I got the point, or oh, I got the point. When it's a deeper, really uncomfortable sensation, could be sharp, could be strictly dependent on the movement you do that might put more pressure there, could be strictly dependent on the movement, I guess, where you're at. Any of those can really be a good reason there. Now, in addition to that deep pain, what you can also feel is increased discomfort when a compression is being applied, right? So me, the clinician, will take your arm and provide a little bit of additional compression into that joint space, again, to put more pressure there, right? Compress it, and then provide some rotation there to say, hey, does that re-elicit your symptoms? That's a very common way. And we can do that in different varying angles too. And we try to do different angles because, again, the location of where the injury might be located can change and be different depending on the person and the mechanism of injury. So the other thing I did want to mention with labrums, because we're going to get into this a little bit later, is instability of the shoulder. Right. So we just mentioned what is one of the big things that the labrum does. The labrum helps stabilize the joint because it's increased surface area. So if that increased surface area is now hindered, it's damaged, it's lost its integrity, you might also get increased instability of the shoulder, feeling like it gets clunky, right? Like it can kind of clunk in and out, and it's uncomfortable when it does so. That can be due to an injury to the labrum, unfortunately. What do we got next, folks? We got biceps tendon injury. Okay. Biceps. I love talking about the bicep because I think there's so much more to it than what we give it credit for. Yes, it's that muscle pump action. For a lot of us, it's one of those cosmetic muscles that we try to work as well. And what we don't realize, right? It's in the name, but a lot of us don't realize that biceps, you break that word down, you have bi, right? So there's two heads to your bicep. The biceps muscle, you have a tendon that goes all the way up and almost into that shoulder joint and is a stabilizer there. And then you also have one that gets stopped a little bit short. So we're going to specifically talk about what's called the long head of the bicep. And that's the one that keeps going into the joint where you see the redness there. All right. So this is commonly seen. Any injury to the biceps long head, specifically that high up. So we're not talking muscle belly. We're not talking lower down by your elbow, specifically at the shoulder. Very commonly seen secondary to labral injuries and rotator cuff injuries. It's taught to be more common with labral injuries because of where it inserts and attaches to, and those tissues can kind of then form in with the labrum there. But a lot of times what I try to say to people is I actually see more with rotator cuffs. At least I have more recently, within the last few years, for whatever the reason may be. And that's anecdotal, but just letting y'all know what I see. Regardless, though, it's very common for both. And the reason why it's common for both is because of how it goes into that shoulder joint and attaches, and it ends up being like a secondary stabilizer to the shoulder joint. So very, very common there to get those injuries. In addition to thinking of it as a secondary stabilizer, I think it's really important to help understand that it also is a secondary helper for raising the arm overhead. And that's why a lot of the times when we're testing the integrity of this particular part of the bicep is we're going through tests like what's called a speeds test, where somebody or me, the clinician, would provide that resistance, but allowing you to go up overhead and doing it with the arm straight there. And we'll see, hey, okay, does that recreate your symptoms in the shoulder? Okay. And do that with your palm up. Another way to test it is you place your hand on your head, and you're going to have pain with this, of course, but hand on the head. Me, the clinician, tries to remove your hand from your head. And if that bothers you, in the spot where you're having your symptoms, again, does it recreate the symptoms that brought you to me, which right now we're talking about the shoulder. If it does, then we have an idea that the biceps is at least involved. And not going to assume that it's the primary source of your symptoms. A thorough exam is needed for that, but we can definitely say, okay, we're grabbing that puzzle piece and we're going to place it on the board. We may not know exactly where that puzzle piece fits yet, but we know biceps tendon irritation is a part of the puzzle. All right. To the next one. The next one we have, folks, shoulder dislocations. Makes me cringe every time. Shoulder dislocations, they're real. They can be due to a number of reasons as well. We mentioned laxity, so that and that laxity potentially being due to a labral tear, right? So that instability, is what the term I used earlier. So those are two slightly different things, instability and laxity. Let me not get you guys confused here. But we mentioned labral tears as a reason, right? And so we injure the labrum. It's supposed to help increase that surface area, give our shoulder more room to work with. When that is now hindered, you have more instability, and therefore you can potentially have a dislocation. Now, laxity that I mentioned before, that's more so not from a localized reason of instability like an injury to the labrum. That's going to be typically due more to you have a large amount of ligaments that just don't have the properties in them to keep them a little bit more taut. So your ligaments, or generalized sense, ligaments that help stabilize and provide that protection around a joint, around the bones, is just quote unquote lax. It's a lot more, there's a lot more play there than what should be there. And then, of course, you can get a dislocation from a traumatic injury as well. Fall, if your arm's in a tough spot during like a motor vehicle accident, any of those reasons, you could dislocate your shoulder. Now, this image shows what's called an anterior dislocation, meaning the ball of the ball and socket joint there is coming forward, right? The top of the upper arm bone. We have a posterior, which just means that same exact ball and socket. The ball is going backwards to the joint. And then we also have what's not shown in this image, inferior, meaning if this is my ball and socket joint, it comes down. Okay, so we have a multitude of ways that we can dislocate the shoulder, and none of them are pleasant. If this happens, folks, I'm going to throw this in here. If this happens, please do not try to what we call reduce the shoulder, meaning do not try to put it back in place yourself, because that can be a reason where you maybe tear your labrum and then you're dealing with subsequent injuries after that. All right, or you could chip a bone. You could chip a bone as well and have like a bone fracture. It's just not worth the risk of doing that. Please go seek professional medical attention if you were to dislocate your shoulder. One thing if you're unsure if you dislocated it, you're most likely going to be guarding a lot. Anything that opens up that joint space is going to feel very vulnerable and therefore very uncomfortable. So you can expect to see somebody have a lot of guarding, a lot of apprehension to movement. And when external support is provided to that joint space, it feels a lot better. Muscles kind of woosah a little bit there. Very, very common to see. All right. Oh, one thing we should mention about shoulder dislocations, and then we're going to keep it moving for you guys, is you can also have what's called a shoulder subluxation. So imagine a dislocation is what you see in the image, where there is a full-on separation between the upper arm bone and the socket of that joint coming from your shoulder blade there, your scapula. Okay. But you can also have what's called a subluxation, where it's a partial. So maybe not 100% out of the socket. Maybe it came out of the socket like 25% or 50% and then was able to go back in. That happened to me once. So I know exactly what that feels like. It is a funky feeling. You still get that apprehension, not as much. You still guard, not as much. Extra protection and stability to it, of course, does still feel better. But a subluxation is when that shoulder might come out of socket. I'm putting that in quotations for you guys because, again, it's not 100% coming out, but it is able to reduce right back in on its own, not with you forcing it in. That is still a dislocation. You just forced it back. A subluxation is the shoulder joint, the nervous system, the muscles, the tendons, the ligaments, everything is able to get that thing back in place on its own. All right, guys, we're moving right along. Hope you guys are able to stay with me here. Now we're at AC joints. Okay, so AC joint injuries, man. Raise your hand if you're a healthcare professional and AC joints just make you so. This is annoying injuries. Okay, because what you see here is the progression of joint separation, but you can also just get irritation to the AC joint. It can just be inflamed and be irritated, and they're just really annoying to deal with. The joint space before your AC joint is so small, right? And just as a reminder, what is our AC joint? That's our acromion, so that's the roof of the shoulder, and then clavicular, which is your collarbone, and those two pieces coming together. And yeah, sometimes you just get irritation to the joint space, and there's not a whole lot you can do. You can really work around it if it's just that irritation, right? You say, okay, well, what are the things that we know we need to potentially improve to help offload the joint itself? We need to maximize our mobility safely. We need to continue to make sure the shoulder blade itself is nice and stable, and then continue to work on stability around the shoulder complex as a whole and building strength as appropriate, right? But outside of that, just time for the AC joint when it's just irritated like that. It's annoying. They're annoying to deal with. Not super common, but these things do happen. I definitely don't see a lot of AC joint. I have one guy right now who we're going to see what the imaging comes back as, because it's gotten better, but certain pressing motions are still kind of giving that very specific discomfort there. So we'll see, just to get some more clarification there. But anyways, you're going to know it by palpating around the joint. That's going to be one of the biggest things. A lot of discomfort at end ranges, like, again, where you get maximal joint closure there, end ranges, especially coming across the body where you've just compressed this whole kind of front top part of the joint there. It gets compressed. That's going to be uncomfortable. Now, what you see here, right, we mentioned this is a progression of the more intense version of what can happen with that AC joint, acromioclavicular roof and clavicle coming together, and that's a joint separation. So you have type 1s where it's strictly going to be some irritation there. You're not going to get a lot more than that, which is a good thing. That's what you want. You don't want a lot more than that. But then you have type 2 here, where you actually start to get some fraying and tearing of ligaments. And then you get type 3, where now not only do you have a separation from one set of ligaments, but you're getting a separation from multiple. That's all you need to know. Like, yes, there's different ligaments. You have your coracoclavicular that you see in type 3, acromioclavicular here. But just know that you're getting multiple ligaments are tearing now. All right, that's all you need to know. And then the only reason why I'm not showing you more than type 3, there are about 6 types in total. From type 3 on, when that clavicle, that collarbone is fully now let go, that's when you need to seek surgical or you need to go see a doctor for that. Okay, these other ones, type 1 and 2, can be treated, and most usually are commonly advised to be treated conservatively. No surgical intervention, right? Everybody's goal is to keep us as non-invasive as possible. That's so important. But with type 3 to 4, 5, and 6, like that clavicle now is doing some funky things, and surgery is going to be what gets that better. Unfortunately, we cannot as clinicians, we can work around it, but we as clinicians are not going to reattach. There's nothing we can do clinically to reattach the ligaments there. So that's definitely something that we're going to need to go see a healthcare professional for. Now, what's good to understand and know, though, is how would you know that you have a separation here that now, like, definitely is out of the hands of a clinician, a physical therapist for you, is very visible. Usually, that's a nice thing. It's usually pretty obvious. You're going to have one clavicle that's either sitting way up, sitting way down, which is even worse, sitting way back, that's even worse. So just as the tears get more and more intense, that clavicle is going to be put in some funky positions, usually very, very visible. Again, very visible there. All righty. How we doing, guys? All right, look, this one is fractures. It's like, it is what it is. It's joint fractures. I had one of these myself. These are just all a bunch of different types of fractures, right? How do we fracture something? It can be a traumatic event like a fall. It could be something building over time. Pretty rare in the shoulder that you're going to have a non-traumatic hairline fracture that then just builds over time, because it's just not nearly as loading of a joint unless you're playing a very unique sport or something. Still can happen though, right? Certainly still can happen, but more than likely a big traumatic event. I had this surgical neck one, so this makes me cringe every time. Still, this was many, many years ago. I was 15, so what got me into physical therapy was fracturing my shoulder here. Some kid slide tackled me from behind. First, it was like out of a movie, right? First game of the season, first like 15 seconds of the game, we get the ball. Somebody passes it to me. I'm dribbling up the field. We're about to dominate these guys. And he slide tackles me from behind. I don't see it coming, completely takes me by surprise. He upends me. I land on my shoulder and just immediately fractured my surgical neck of the shoulder there. Shout out to my surgeon, though, because we're doing good now. So, yeah, good old-fashioned joint fractures. Now, here we got shoulder arthritis. So one of you guys had asked me, can you talk about inflammation of the joint a little bit? And that's exactly what shoulder arthritis is. It's inflammation. We got that itis. It's back. Itis and arthro mean joint. So we have some joint arthritis here. Now, you're seeing a very intense version of this in the image looks like it's from Cleveland Clinic in 2025. Shout out to them, because, again, I don't own any of these photos. So that's a really severe version, okay? We're going to break this down a little bit. This is something that everybody gets. So I want us to end right here and now. We are going to end this terrible, taboo, oh my goodness connotation of somebody tells you have osteoarthritis, meaning just bone arthritis there, and it being this there's nothing I can now do mindset. We need to change that in healthcare, and especially in physical therapy, especially the more and more we become the first point of defense, okay? Primary care providers. Because everybody gets this eventually. Now, there are varying levels, like you see here, a very intense level. And yes, some people get this sooner than others, depending on how active you may have been or what injuries you may have come across. But at the end of the day, this happens to everybody. This is a very, very intense version. What you're seeing here is a different type of cartilage. So not necessarily the labrum, although labrum, maybe has been worn down at this point, especially in this image, my goodness. But there's a different type of cartilage that sits at the end of the bone and looks kind of shiny and opaque there. And that cartilage, or hyaline cartilage, has been worn down. Okay, like I have that probably in my shoulder from my fracture. Definitely got that going on in my knee from a contact knee injury, also playing soccer. We'll talk about that more when we get to the knee. But there are a lot of things. Most of us are catching this sooner than this picture. So I'm trying to get at, guys. This picture is a intense version. Okay, so bear with me here. It's a good picture because it highlights a very healthy shoulder, quote unquote healthy shoulder, and then this intense version. Some people can have this version here and not even have symptoms, not even know, right? But here's the thing: a lot of us can catch this early, and we can slow down that process. How do we slow down that process? From an orthopedic standpoint, well, let me throw this out here. I am not specialized in this, so I can only say so much, but a lot of what we can do too is our nutrition. Something I'm working on myself. Nutrition can help out a lot, trying to reduce all the inflammatory foods we eat to help our bodies recover and heal faster when we are putting more stress onto them. But if we stick to just orthopedically, what can we do? We can still maximize a safe amount of joint space in the joint. So to offload some of that, we can maximize stability around the joint, which again can offload some of that and then maximize overall mobility, not just in the joint space itself, but mobility in the shoulder complex as a whole. Okay. Now, when we say we can offload this, we're talking millimeters here. Okay. So that's, I mean, we're not going from here all the way to, here. We're really talking millimeters, but that millimeters can make such a big difference. So there are a lot of us out here we can catch this early and address it early. Don't let somebody tell you, oh, you have arthritis, you'll need a total shoulder arthroplasty, which is just a shoulder replacement, no matter what. Like, that is not the case. I can't stand when people say that, because that is not the case. You got years to be able to minimize this progression and hopefully stop it in its tracks as much as humanly possible. All right, that's my rant on arthritis there. So what can it feel like though? Again, you can just have like deep pain and discomfort. You're going to have some restrictions in mobility. Depending on where the arthritis is most prevalent is going to depend on where you have more of your mobility limitations. With the mobility limitations, right, what tends to happen, well, we're going to really cap how strong our muscles can get. So you're going to maybe see a slow decline in strength and stability because you're no longer using your muscles to their full capacity as well. But again, I think the biggest takeaway from this is very common. It happens to pretty much everybody. And most of us are not being honest with ourselves of how early we catch something like this and then make the necessary changes, whether it be lifestyle changes, exercising changes, in order to help mitigate this as much as possible. Okay. All right. Again, that's my rant on shoulder arthritis. Yeah, I got a little too excited there. All right. And then we have frozen shoulder. So the last one we're going to talk about today, guys, frozen shoulder. I also have a little bit of a gripe with frozen shoulder. I believe this is a personal Jared thing. So, take it with a grain of salt, but I believe that frozen shoulder is way overdiagnosed, or at least it used to be. I don't see it as much anymore. I feel like there was about a 5-year span where everybody's getting diagnosed with frozen shoulder. Yeah, you got your shoulder stiff. Oh, it's probably just frozen shoulder. It'll get better in 2 years. Now, can frozen shoulder still happen? Of course, but let's not just jump to conclusions and in a lazy effort to give a patient an answer that puts as much of the workload on the clinician by just saying it's frozen shoulder. Okay. What are the most common? We don't know, if I'm being honest with you. It's not 100% clear what causes frozen shoulder. We don't 100% know. The only thing the research has really shown to show some direct correlations to this, or the two most common things, are diabetes. So a history of diabetes. I'm not sure if type 1 or type 2 matters. So I'll try to do some research on that for you guys. But diabetes, and then a history of thyroid dysfunction. So like maybe you're somebody who's been diagnosed with hypothyroidism. So with those two different types of diagnoses, they say you can be at a higher risk of getting frozen shoulder. And then the other risk of frozen shoulder is if you've had it before. So let's say you had frozen shoulder on your right side, whatever malfunction was going on in there does make you a little bit more prevalent for that to then happen on the left side, the left shoulder. It's the only joint where this thing randomly happens. Again, they don't fully understand it. It's very unique, very interesting, and again, I think way overdiagnosed. And I wouldn't be surprised if a lot of you out there have been diagnosed with frozen shoulder and you didn't really have frozen shoulder. But that's a time for another day. All right. What are the phases of frozen shoulder? So here's the most common phases of frozen shoulder. Again, this image I love. I don't own rights to it, but I love because it shows you a quote unquote healthy shoulder joint and it shows you a not healthy shoulder joint. So what is it? Okay, frozen shoulder, I should probably talk about that first. Frozen shoulder is the layman's terms for the capsule. So we talked about this in the first episode. Imagine your joint having a capsule or like an eggshell that surrounds it to protect it. Well, that eggshell, that capsule, has now gotten significantly smaller and has gotten irritated. We do not know why, but again, that's what happens with frozen shoulder. Now, there are phases to frozen shoulder that they've seen over years of research. There's 4 main phases. You have this pre-freezing phase. So imagine this being like your itis, the inflammation part, where you're just getting that initial irritation and inflammation. It's starting to hurt. You don't really know why. We call that the pre-freezing phase. That can last anywhere from 1 to 3 months. Then you have the freezing. So that the pain has set in. But now you're just getting more and more joint stiffness as well. It's getting tighter and tighter. You're working really, really hard to mitigate this. You're stretching, but it's just getting tighter and tighter. That's about 10 weeks to 3 months, they say. And then it's frozen. That's phase 3. So the frozen phase, that can last anywhere from roughly 4 months to a year, maybe even a little bit longer than a year. Hard to say. Maybe I've seen some research say as much as 18 months. Now, the nice thing about frozen shoulder, we just really crapped on it for a little bit, but the nice thing about it is that in most cases, almost all cases, it's going to thaw on its own, which is the final phase. Funny how they came up with these phases, right? So we call it frozen shoulder. You have a pre-freezing phase, then a freezing phase, then a frozen phase, and then it does tend to thaw. And it's literally just like it sounds. All that restriction and irritation slowly starts to loosen up and open up for you. I mean, they don't really know why it does this, and the body's able to help correct itself. So some of you might be saying, well, okay, what do we do about this? Well, where physical therapy comes into play, if this is truly the diagnosis, where physical therapy comes into play is we help really reduce the risk of any subsequent injuries through this process. Because what I have seen for the rare number of patients of mine that have had frozen shoulder, and it's actually be frozen shoulder, is because the understanding isn't there of what's going on. We're trying to push what's not there. You're constantly fighting up against the body that is constantly fighting you right back. And so we make these unhealthy compensations. We push for movements that aren't there in the shoulder. And as a result, we might get that labral injury, or we might get that rotator cuff injury, or we might get that subacromial impingement syndrome injury. All of those different types of injuries, biceps tendon might get injured here, right? And so all of those different types of injuries can occur from us not understanding what the body is trying to communicate with us. And instead of just taking what the body gives us, managing and working around it safely, we end up compensating and can get hurt. So these are the primary injuries that I tend to see as an orthopedic clinical specialist and the clinics that I've worked in over the years. Again, drop in the comments if maybe you've had an orthopedic injury to your shoulder that was not mentioned here. I purposefully did not mention things like thoracic outlet syndrome. That deserves an entire episode on its own, out of respect to thoracic outlet syndrome. And any of you that have dealt with that, you get it. So yeah, I purposely didn't include anything there. I didn't include any injuries to some of the larger muscles like your pecs or your deltoid, or maybe like I don't think this would really be going into the shoulder too much, although technically it does, like your mid traps or your rhomboids, like any of those types of other muscular injuries. I didn't include on purpose. I didn't include like anything going through the accessory muscles of the neck, even though they do help support the shoulder. So just keep that in mind, guys. But drop something in the comments if you have a question. If we want to nerd out a little bit further on a topic and have some fun back and forth, let's feel free to do that as well with me in the comments. Give this video a like, a share. Please subscribe. Follow us on Instagram. I'm going to shamelessly plug all these things, guys. So help a brother out. This has been really, really fun. This is what I love to do. Next episode. So what can you look forward to? Next episode, we're going to go over some foundational exercises to help address some of these injuries. Now, the nice thing is a lot of times when it comes to the shoulder joint, things get way too people try to get too complicated when it comes to treating the shoulder. One thing I love about treating the shoulder in particular is a lot of the injuries that we talked about today, from a clinical standpoint, we're going to start treating them the same. It's the same big things. We need spine mobility. We need proper and safe within what the shoulder can tolerate shoulder mobility. How's your scapular strength and stability? Those are going to be the things we cover in the next episode. Thank you. Appreciate you guys. As y'all know, let's find something in this crazy world to stay happy about. Let's continue to work on our health and stay healthy. But please, never satisfied. All right, folks. Till next time.